Sure. Good afternoon, everybody. My name is Brian Landy. I'm an officer with the Richmond Police Department, and I'm assigned to the county's mental health evaluation team for West Contra Costa County. Just by way of background, I've been a police officer for about 13 years. About half that time has been with various sheriff's offices, and then back in 2015, I came over to the Richmond Police Department. And to some extent, one of the reasons I came was because the county had the mental health evaluation team, and Richmond Police Department was participating in that program. So today, what I will be doing is just kind of giving you a rundown of what our team does. I'll also touch on some of the other resources that are available in the county. It is not going to be exhaustive of mental health services in the county. There are many. But I will talk about some of the various resources and teams that are associated with the MET team. So primarily be talking about county programs and programs that are tied to adult behavioral health or health's forensic program. The presentation I'm going to show you is this is the presentation that we provide to law enforcement agencies. So you're going to get the same kind of overview of what we do that I provide to all agencies in the county, even some agencies out of county, so that you have a better understanding of how our team works and how law enforcement interfaces with the mental health services that the county provides. And then I'll be more than happy.
That sounds really good. And I'm having some technical problems, Officer Landy, I'm still trying to pull up the presentation, and hopefully I'll be able to do that. So maybe you might want to go ahead and start, and then hopefully I'll be able to bring it up in a moment. I'll keep on working on it.
Sure. So I do not have the presentation in front of me. Unfortunately, I'm coming back from another training in Oakland, and I was not able to make it back to the station due to traffic. But I'll just begin with an overview of the mental health evaluation team. So the mental health evaluation team was started in 2015. It is a county-run program through adult behavioral health. The goal of the MET program when it was stood up was to use a co-responder model of mental health intervention. Co-responder just means that it is a mix of law enforcement and clinical specialists. So that might be marriage and family therapists or clinical social workers. And our job is to go out in the field together and interact with and engage with members of the community with mental health disorders and issues, primarily that are having contacts with law enforcement. So the goal is for us to try to impact kind of underlying causes of law enforcement contact with individuals who have mental health issues, and try to reduce those contacts through kind of creative problem solving, getting people connected to services, and other problem solving, and also to reduce their patient or client visits to what's called PES, or the Psychiatric Emergency Service. And just to clarify what that is, the Psychiatric Emergency Service you can think of as the emergency room or the emergency department for individuals having a psychiatric crisis. So when we normally talk about putting somebody on what's called a 5150 hold or having somebody involuntarily committed, what we're really talking about is an officer coming out or a clinician coming out from the county and putting somebody on a temporary hold to be transported to a specialty emergency department. That emergency department in Contra Costa County, the only one that is authorized, is at Contra Costa County Regional Medical Center in Martinez. So while there are a variety of different emergency rooms throughout the county, the only place that's authorized to take involuntary holds for assessment is CCRMC. So we've been around long before these types of programs became popular in the last year. We've been in operation since 2015. Initially, the pilot program started with 3 police departments on contract to the county. And here we go. Since then, that has expanded to 5 agencies providing officers and now deputies to support the county's team. The teams historically were divided up into 3 different regions. There is a West region, which I provide services to, a Central region, and a East region. So the West region, which encompasses Richmond, is basically everything from El Cerrito up to Rodeo and parts of unincorporated Martinez. Since the sheriff's office began participating in the program last July. They now have a deputy that helps cover part of unincorporated West County. They'll be bringing on 2 more deputies starting this July, so that there'll be a dedicated West County deputy that I'll be working with, in addition to hopefully a new West County clinician. So hopefully you can also now see the presentation. Like I mentioned, mental health evaluation team is a co-responding model. It means it's interdisciplinary. I'll talk a little bit about the benefits of that in a bit, but it just means that, you know, we go out. We're not like normal patrol officers. We dress in modified uniforms for the most part. We drive unmarked cars. The goal is to be, a lot more subdued a presence. We're not out doing law enforcement or, investigating crimes. We get referrals from law enforcement agencies, like I mentioned, to try to impact high utilizers, either of law enforcement services or of the psychiatric emergency service. And I do want to note that the MET team in particular, unlike some of the other kind of our cousins at the county, we are law enforcement referrals only. So we're not a very public facing unit. We get our referrals from law enforcement, not from the general public. Within the law enforcement community, we can accept referrals from any law enforcement agency. And that also includes, for example, the district attorney's office, the public defender's office. So some agencies that you might not even think of as traditionally law enforcement, as long as they're part of the criminal justice system and are dealing with kind of the criminal consequences of psychiatric crisis, then we can take a referral from them. And there we go. Like I mentioned, our goal, our objectives are to reduce, again, PES visits. That means visits to the psychiatric emergency service, where 5150 holds, to use the more law enforcement term, reduce inpatient hospitalization. So when someone gets sent to psychiatric emergency service, if they are deemed to be needing kind of further medical treatment and stabilization, they don't stay at Contra Costa County PES. They'll either go to one of the 2 inpatient units there or be referred out to another inpatient hospital. And so that's where the longer 2-week stays usually occur, anything beyond 72 hours. So we try to reduce those through prevention, getting people connected to services, et cetera. I already mentioned reductions of police calls for service. A big one for us is trying to reduce the likelihood of arrest or rearrest. So if we're able to get at the root of kind of the criminogenic kind of causes of the behavior, or some of the psychiatric causes of criminal behavior, we'll try to mitigate those to prevent future arrests. So we'll talk a little bit more about, why having law enforcement involved in mental health response, both on the crisis side, on the follow-up side, is important for doing harm reduction and mitigating arrests later. And then the big one that, I think everybody's been most interested in lately is kind of reducing violent encounters between law enforcement and those with individuals with psychiatric crisis. They're not in bold. I'll get into that more too. That you might have seen that mentioned, education. Specifically, I think that's meant to refer to education to family, friends, neighbors, what we call psychoeducation. So a lot of the work we do is supporting the people and the community around an individual, not necessarily providing just services to that individual. So how do we do this? The core of MET is providing voluntary services. So we don't go out into the field to give people or put people on involuntary holds. We typically get involved after law enforcement has already done that, after somebody's been in crisis, now they're out of crisis, and now we need to figure out what can be done to prevent this from happening again. So one of the things that the clinicians, the community support workers, peer support, some of the other members of the team that, both in the field and back at the office do, is help, when we go out, make contact with an individual, they've already been treated, maybe they've been medically stabilized, they're back home, they're calm, they're not experiencing psychosis. So now we can sit down and have a conversation with them and try to find out whether or not they've been connected to services or not. One of the main things we do is what's called intensive short-term case management. So for about 30 to 90 days, we do intensive follow-up, trying to make sure that person gets connected to the right long-term case management. In some cases, that might be getting an individual opened up at West County Adult Behavioral Health. That's out on San Pablo Avenue. That might just be getting them in for an initial full psychiatric evaluation. They will not get that at the psychiatric emergency service, not unless they go for inpatient for some time. Other times we're trying to get people placed at residential programs, or we might be trying to find kind of long-term services through a program like Hume. We send people to Hope House for step down, after they've been to psychiatric emergency service, but they're not quite ready to return to the community. But because we're a county unit, and again, MED is not a Richmond Police Department program, it is a program of adult behavioral health at the county. It means that myself and my partner have access to the entirety of the county's public health resources. It's one of the big differentiators between what makes, I think, our program successful in West County versus what I see in San Francisco City and County, or even over with our counterparts in Alameda. They don't have this level of integration between law enforcement and the county services. And so they're not as able to do the wraparound services, the long-term case management, or getting people connected to long-term case management. We spent a lot of time working with individuals and families on how to access services, navigating services. And as I mentioned before, probably the most important thing we do day to day is working with the families and loved ones of somebody who's been having crises, with having them have a better understanding of what resources are available. Just as an example, a lot of times we see family members are calling 911 and asking the police to get involved in a mental health crisis where they actually could be reaching out to another service, but they weren't aware that those services exist. Sometimes that might be knowing that there is a unit called Mobile Crisis Response, which does come out for someone who is not a danger to themselves. It is not, a danger to the public, but they're experiencing some level of crisis that's overwhelming that individual or that family's ability to respond to it. They don't really need the police to come out and provide that level of service. Things are already relatively safe, but the person needs some immediate treatment. So we would help educate the family on how to access mobile crisis, how to articulate their needs to mobile crisis. A lot of the times what we find is that when people are trying to access services, they don't actually know how to articulate the problem. So sometimes their requests for services are going unmet, not because they don't see a need or even know where to go, but because they don't know how to ask for what they need in a language that will be understood by the service provider. And you can move on to the next slide. We provide services exclusively to adults. We do not provide services to a range of other populations, specifically juveniles, those with developmental delays or disabilities, dementia, Alzheimer's patients, or primary substance abuse. Part of the reason for this is that adult behavioral health, most of the 60 or so county Medi-Cal programs are when they get their funding, they have to bin everything by different populations. So if you have a developmental disability, you're going to be getting your services through a funding stream in Medi-Cal billing that is going to be through one of the 21 regional centers. So for example, if you have autism, you're going to get your services from the regional center of the East Bay. So even if you are having a crisis, the police get involved. The police make a referral saying, oh, this person's having a psychiatric issue, but it turns out that individual is autistic and getting services from regional center. We will then refer that individual back to the regional center. They also have their own crisis response team called, if I can remember it correctly, I think it's called the Crisis Response Project that does some of the same things that we do. They aren't co-response, but they do provide a kind of, I would say, nice mix of both mobile crisis response along with the short-term follow-up. We also, if you can go back, we get a lot of calls for individuals who have dementia or Alzheimer's. Again, we can't really assist with that. Our services are set up for people who have treatable mental health issues, dementia, Alzheimer's, those are degenerative organic brain disorders. Psychiatric emergency service, the MET team, we're not equipped and resourced to provide those services. There are other service providers at the county, like adult protective services, that help kind of orient people to the medical services they'll need for that. And it's the same for primary substance abuse disorders. So people who are having psychosis as a result of substance use, we don't do alcohol and drug services, but we can refer that person to one of the county's AOD programs. Okay, We can go ahead and advance. I've already gone over the history of the program, so we can skip that slide. This is mostly information that we give to the law enforcement agencies for the different regions. You can advance through all these. So they're just the different officers and clinicians assigned to the different regional areas. As I explained earlier, I am the Met West officer. Right now, we don't have an assigned clinician. I share a clinician with Central County, and right now it's no longer Elon Hunt, it is James Lancaster. Okay, so I mentioned that we are a referral only service. That means that we have to get our referrals from law enforcement. This just explains to the law enforcement agencies how they make a referral. All the 26 law enforcement agencies in the county have liaisons. They screen their 5150 reports or contacts. Again, 5150 just being the law enforcement kind of term of art for talking about somebody who is having a psychiatric crisis and is being placed on an involuntary detention for transportation to a psychiatric facility. The liaisons will send us a referral containing certain specific information that is required by the county. We then review that information. We will pool both mental health records and law enforcement records to see if the person meets the criteria for the MET program. And if they do, then we will take them on as a client. If not, we usually still do what's called a one-shot, which is we still try to provide some kind of referral to the appropriate service, or provide some type of education to family or the reporting party that initiated the contact with law enforcement. So we still try to do something, even if we can't bring to bear all our full services. This isn't too important for all of you. This is more, again, for the workflow for law enforcement agencies. So it just explains, law enforcement will have a contact. It might be, let's say, somebody who's been placed on 12 psychiatric holds in the past 8 months, and law enforcement's just not able at the patrol level to figure out how to mitigate future contacts. They'll send us a referral. Those referrals have to meet certain types of criteria. So, for example, we can't take any and all individuals who've been placed on a hold. There has to be something like they have been placed on a large number of holds over a short period of time. They have a history of violence in the community or violence at home due to their psychiatric condition. They've been involved in a barricade or kind of as a barricaded suspect or hostage taking situation as a result of their psychiatric condition. So the clients that we deal with are very much individuals who are at risk, or the most at risk in the community for being a harm to others. We don't deal nearly as much with individuals who are gravely disabled or a danger to themselves. We might, especially if it's causing a repeat psychiatric contact or contact with psychiatric emergency service. But primarily, we're getting involved when there's a significant public safety component, or where someone's psychiatric condition is impacting law enforcement resources to the point that it's causing a public safety issue. We call those high utilizers. This is just the minimum information that we need a referral. You can move past that. These are our emails. You can advance past that. That's just more about our workflow. We can advance past that. I know it says Q&A, but before we jump into kind of getting deeper into any questions that you have or the service you provide, I did want to mention that my team is located at a subunit of County Adult Behavioral Health. It's in the Forensics Department. We work with a bunch of allied teams, all in the same office. That includes the diversion program, the courts, the Laura's Law folks. That's what's called advanced outpatient treatment. That provides a kind of court process for individuals who are having pretty severe mental health issue and they need the courts getting involved in court orders for their treatment. We have people from the or the public guardian's office come by, but they're not housed with us. Up until very recently, mobile crisis response team was housed with us. They are now in a new component of the county called A3. I don't know what A3 stands for, But it is a unit that will house now both a mobile crisis response team, and then Seneca has a contract to provide the same services to juveniles. That's called the mobile response team. They are excellent. They're all going to be in the unified office. They'll also have a respite facility in Concord, I believe. I think they're looking at opening that up. It will eventually, that the A3 unit should have a fairly large staff of, I think, ideally 72 individuals. I think it's going to take some time to get that staffed up. But those are the agencies that, or the teams that we most frequently are working with. We do have, work with many of the CBOs, or community-based organizations, providing psychiatric services or clinical services throughout the county. Whether that be, programs like Hume, Hope House, Trinity, we work with all the various providers in the county. Even though most of our clients are on Medi-Cal, we do have the ability to work with individuals who are Kaiser, HealthNet, Anthem. We have financial counseling services to the county. There are plenty of times, even with the folks that we work with in Alamo and Danville and Blackhawk, they're not getting the services they need. So one of the things we'll often do is help them transition from their Cadillac plan through Anthem over to Medi-Cal, so they can get the best possible behavioral health services. So it's fairly comprehensive. We go pretty deep in the weeds, looking at people's situations, kind of in a well-rounded, holistic approach. And we have the time and the resources to be able to do that, so that we can free up the law enforcement agencies to be what they are, which is first responders. So at this point, I'm happy to take any questions that you might have, and thanks for having me.
Yeah, and Officer Landy, can you talk a little bit about maybe your background and how you got into this work before we take questions? And then we can take questions either with people using the raise your hand feature, or if you want to drop a question in the chat, feel free. And I did drop the link to A3 in there. A3 is a separate program than MET, but I wanted everybody to be able to have the information for A3. So go ahead, Officer Landy.
Sure. So like I mentioned, I've been a police officer for about 13 years. I've spent most of that time either as a deputy or in patrol. I've also been a school resource officer. I do have a bit of a unique background. I do have a PhD from Cal. My background there is a social psychologist, so not in a clinical side of things, but on the research side of things. So I do have a little bit of extra knowledge that I'm able to use when I'm out in the field. I also have been lucky enough to be tied in for the last decade or so with some of the other kind of, I would say, leaders in kind of crisis response in the area at SFPD and OPD. I've just been fortunate enough to be around the crisis intervention, kind of the development of crisis intervention work for quite some time.
Yeah, and I remember when I first started talking to you about this new assignment, you had said that this was really your dream job. Why? Was this why you got into law enforcement?
It's not why I got into law enforcement. It is one of the major reasons I lateraled over to Richmond PD. The MET program is pretty unique. There really isn't much like it. LA has a program that's fairly similar. But there just aren't any or many co-responder models where law enforcement has the ability to work in an interdisciplinary way to really try to investigate and understand, and not just investigate in a law enforcement sense, but in a clinical and kind of forensic sense, kind of why a problem is occurring. And so the ability to take time, get to know people, build very, very long-term relationships. I work with clients consistently, weekly for, a year or more, where we are, building very substantial relationships, very deep relationships, but also able to bring to bear resources that neither patrol nor outpatient clinical services are able to bring to bear on a problem. And I think if you're in law enforcement and you want to help people, if patrol is a very difficult place to fix these types of problems. You need time, you need non-law enforcement resources, and vice versa. If you're a clinician, without the ability to get out safely into the field and interact with people who are often in a state of psychosis, with very real histories of violence, both towards family, to themselves, towards the community, it can be a challenge to get this kind of work done. So it's what attracted me to being a school resource officer. Some of the same ability to impact people's lives in a not just a one-off kind of band-aid way, but to both do the kind of preventative care and then the follow-up care. And so for me, it's this is the kind of work I enjoy. I'm not particularly interested in doing other work other than this kind of level of service delivery. But there just aren't many places that you can do that. Richmond had the foresight to jump into this very, very early on with no guarantee of success, and then to be, I think, the only agency that I think Richmond's the only agency that has persisted in participating in the program.
Thank you for that. So I do see that there are some questions, so feel free to raise your hand. Cordell, you have your hand raised first, so go ahead first with your question, and feel free to raise your hand or drop questions in the chat.
Okay, can you hear me, Michelle?
I can hear you.
Good. So thank you, Officer Landy, for that presentation. One of the things that I have noticed is like, okay, I just remembered when you have you talked to some of the businesses that okay, let me rewind that. Will you be engaging in some of the businesses around Richmond to get them involved, like, you know, with mental health? You get what I'm saying?
So, I mean, we do get involved with businesses when there's a more immediate issue involved, but we don't do a lot of organizing and advocacy at that level. There's other groups around Richmond that are better equipped to do that. But we do get involved, for example, if the business are having an issue, for example, like on Ryden Road, we do get involved in consulting with them. But again, it has to go through the referral process. There's usually some law enforcement nexus. Sometimes that is coming from crime prevention. It doesn't always have to come from an officer, where there needs to be additional support. But our resources are also limited. So most of what we're doing is the intensive case management and follow up for specific individual clients throughout West County.
Thank you, and thank you, Cordell.
There does need to be more. There does need to be more organization mobilization for mental health services, especially in cities like Richmond.
Absolutely, and thank you for that great question, Cordell. Yinny, I see your hand is up. Go ahead.
Yes, hello everyone. My name is Yenny Garcia. I'm the chair to the Community Police Review Commission, and I'm really interested in the A3 model. Hopefully it gets started soon, and I was late, so I apologize for that, but you might have covered this at the beginning. I have questions around how many are in your team and how many Spanish speaking officers or team members are there?
I believe we're getting I think we used to have Spanish speaking team members. We don't currently, but I believe one of the new deputies is going to be Spanish speaking. But there's currently, there are 4 officers. We lost our 5th one. He just retired. I don't know when he's being replaced. That's the Concord program, but that's a little bit of a different program because their program is the city is contracting with the county to get their own clinician. So they don't participate at the same level as the other cities where we're on contract to the county. If we need help with Spanish language translation or any language translation, we have a wide range of resources available. So I usually have access to clinicians from around the county that are able to come out into the field. We just dealt with a Laotian family where we brought out a clinician who speaks Lao to help us out with that. So we are very fortunate to have a pretty deep bench, both within the county services, but also the various providers around the county that collaborate with the county behavioral health services to be able to meet those kind of both language needs, but also we deal with a fair bit of kind of cross-cultural issues throughout the county and having to navigate fairly complicated both religious issues, cultural issues, and how those impact access or utilization of services.
Yeah, I was just asking, I'm sorry, a follow-up question, because there's been a lot of concerns with, people not getting medically assessed, or I forgot the word, but because they're undocumented or they don't have Medi-Cal. And now the county actually is going to be offering Medi-Cal, and there's the CARES program, and just having that information translated over when you're dealing with folks or their families in the middle of their crisis. I think it's important to have Spanish speaking folks that can give that information, because I feel, at least in some of our communities, they don't seek treatment or they don't want to go with the clinician that comes out and helps because they don't have Medi-Cal. And so having that information transferred over.
Yeah, so that's going to be something A3 will have to figure out. We're a separate entity from A3. We don't do crisis response. It is very rare that we have to put our clients on a hold. It does happen. But if we're engaged with somebody, we're already now helping them navigate the financial side of it. So the county is pretty good at doing the financial counseling. I did touch upon it earlier in the presentation, but we're pretty good at getting people into Medi-Cal. It's only ever a barrier when, I would say in our experience, it's not so much people who don't have Medi-Cal, it's that we have somebody who is on another private insurance or employer insurance that's actually not adequate for their behavioral health needs. And so trying to get them onto Medi-Cal so that they can access county adult behavioral health. Contra Costa County does allow people to do that, which is, I would say, unique from my understanding of what other counties allow.
And if I understand, Officer Landy, just so that I'm clear, because I think a lot of people ask this question, like, well, what's the difference between AA3 and MET? You know, MET really is specifically the co-responder model, correct?
Right. So it's not just that we're co-responders. I would say A3, if you want to think of, just to use the policing model as a metaphor, if you think of your patrol officer as the first responder, and then you have detectives who come in after the fact to do the investigations and kind of figure out what to do and do the follow-up, we're more like the detectives. So A3 goes out, deals with the initial crisis. So does law enforcement patrol officers. We then get a referral from law enforcement agencies. We do sometimes get referrals from A3. That's not the normal process, but there are cases that A3 will come to us with that they're not able to handle, and then we'll take those over. But we come in and do kind of more the root cause analysis, looking at medical records, law enforcement records, trying to understand a problem through follow-up interviews with family members, the client, the community members, neighbors, and try to get a better grip on what the problem is and how to come up with a more permanent solution. So again, we don't typically come out unless there's a very significant crisis. We do get called out for crisis negotiations or extremely complicated crisis response situations where a higher level of service is required. So we will come out and support A3 or law enforcement under those conditions. But we're not we basically work by appointment, if that makes sense. We make appointments with our clients and do the follow-up.
Thank you, and that's helpful. And I had another question that was sent to me. What is CIT? And I know you're in CIT training right now. That's why I'm glad that you were able to join us, even from the car, which we're totally okay with and appreciate. But what is CIT?
Sure. CIT stands for Crisis Intervention Teams. It is a model that comes out of Memphis in the late 80s and early 90s for training officers to have a better understanding of a psychiatric crisis and how to respond to it. It is one of the kind of evidence-based models. There are several evidence-based models for responding to individual crisis that have been shown to be successful in lowering rates of arrest, police use of force, getting people diverted to the right place, namely the psychiatric emergency service or to a hospital, by providing teams of officers who've been specially trained to respond to crises. CIT has also come to take over a bigger, I'd say, concept. There's been some concept creepage over the last 20 years or so. So a lot of times it just refers to crisis intervention training. So these aren't formal teams, but let's say Richmond might send an officer to an 8-hour class on kind of the basics of recognizing, when an individual is having a psychiatric crisis instead of being a substance abuse, or whether or not this is a crime versus a psychiatric issue. And so it just often will also refer to the training component of getting officers better skills for responding to people with crisis. So that's kind of the various meanings of CIT. I've done CIT numerous times over the last 15 years or so in different states. I've watched it evolve. Some of the trainings are quite good. Depending on where you get it, it can be less good. It just kind of depends on who the providers and vendors are. But it's something that the state requires some now minimal level of training to all police officers as part of their police academy training and their in-service training every few years.
Thank you. I don't see any other hands up. Were there other questions that people had? Feel free to raise your hand or drop it in the chat. It's a lot of good information to take advantage of. You know, I had recently pulled up some of the stats that we had on 5150 calls. You know, we get quite a few of them, and obviously a lot more that don't necessarily meet that criteria. So this is probably one of the most important things that we can tackle, I think, in law enforcement today, is how we respond to mental and behavioral health crisis more than anything else. And I really appreciate working with you, Officer Landy, and your team. I've called many times to try to get client support and help, and you've been able to be helpful and resourceful. What kind of things can neighborhood groups do to help support the work that you're doing? Is there a role for neighborhood groups to help support if they know someone who is in crisis, or maybe it's one of those repeat call for services that you're talking about? How can they get help for someone?
Yeah, I mean, I think one of the things that the neighborhood groups can do is just be aware of what the various resources are for what level of severity of a problem. So, the police department, as you know, is suffering, not just our department, but most of the departments in the area are suffering pretty severe staffing shortages. And we get, about 1,600 calls a year just for the city of Richmond for people who are believed to be requiring police contact due to a psychiatric crisis. The reality is most of those people do not need the police to come contact them. They need somebody to come check on them. But having kind of a knowledge of what your other resources are, like mobile crisis for adults, mobile response team for juveniles, you can access both of those through the 211 line. So it's pretty easy to call. Unfortunately, our dispatch cannot call these services for you. The intake process is about 10 to 15 minutes, and our dispatching is not staffed at a point where we're able to take, and I would say none of the dispatches around the county are able to do that right now. We may be seeing a change with the county being able to take calls and dispatch those teams through their dispatch, but that's very much in the works. That's part of the A3 plan, and that has not been solved. So just knowing that those are available, knowing when somebody, they may be psychotic and saying, bizarre things and being disconnected from reality, but knowing when they're truly a danger to themselves. We can't take, most of the people that we get called about are usually having some kind of psychosis, or they're hallucinating, they're hearing voices, they're saying things that are very uncomfortable. They're not things that law enforcement can act on. And so having a good sense of when you do need to call versus initiating contact, where the police have to come out and have a contact that doesn't actually have a public safety dimension, can be a good way to help mitigate unnecessary police contacts with individuals with mental illness. We get a lot of 5150 calls, again, those mental health calls, for people who are primarily they're homeless or have substance abuse issues. And unfortunately, that is not something that the police department can really help with, but it might be something that CORE can help with. And CORE has the contract for Richmond and San Pablo, and also for the county for doing homeless outreach. So just knowing, being educated on that those are options, that it doesn't necessarily require the police, the fire department to come out. Understanding the limitations of what the police can do with people who are in psychiatric crisis. We're very, very limited. A lot of people they don't understand why, when they call about somebody who's saying what they believe to be inappropriate or sometimes dangerous things, the police come, they put them on that individual in the back of an ambulance, they go away, but they're back 4 hours later. And it's just understanding that the police don't control that process. That's controlled by clinicians and psychiatrists at the Psychiatric Emergency Service, who have deemed that person does not meet the medical necessity criterion to be held any longer. And so they were released. So other things you can do is just building relationships with people in the community, being aware of some of the other community-based organizations There's a lot of mental health resources in the community. They aren't necessarily part of the city of Richmond's, services or the county's resources. But NAMI does a great job. They're a great resource. There's just a lot out there, and there is information available on how to get additional resources for people. There's a lot of crisis lines out there that people can be referred to. So certainly, keep us in mind, if you have a question or kind of curious about who you would even want to contact or need to contact for an issue, that is something that, myself and Michelle would certainly be happy to help, point people in the right direction.
Thank you. Yeah, and I'm going to drop the number for Contra Costa NAMI into the chat so that people have that as a resource. It is a great resource. And Kristen also mentioned getting people trained in mental health first aid. So a couple years ago, we did get community members. I believe it was something close to 125 trained in mental health first aid through the county. They actually provided the service free of charge. And it's kind of like, the way that you provide that service for people who get CPR, it's kind of giving community members a first line understanding of, how to understand, not to be clinicians, but how to understand mental health and mental illness, what signs to look for, and how to get resources and help for people, and just how to be better positioned and prepared to help folks who might be experiencing a crisis. So maybe that's something that, as a follow-up to our discussion here, I could do is check in with the county and just kind of see whether those services are set up. I believe at the time you had to have 15 people who were interested in taking the training because it was an 8-hour training. But I'm happy to reach out and see if that's something that's still available, because I do think that that's a valuable resource. And I also see in the chat more support for mental health first aid in communities and understanding. So those are the couple of things I see. I don't know if there, there is one other question. I'm sorry.
I can also make another suggestion, which is the cases that are often most visible and that we get the most calls for are people who generally have pretty severe psychosis. And one thing that you can do as a community is try to advocate for things like sobriety centers or sobering centers, where, police, fire can take people who are having substance abuse. They should give them an alternative to a jail or to the psychiatric emergency service. We don't have that in West County. You could also advocate for the county at the state level for more there are many different types of inpatient beds that individuals with severe mental health need. Part of the reason those individuals are back on the street is no beds were available. And without people asking for those services and demanding them from the state, from the county, from the city, not that the city can provide those services, but at least having that pressure put on decision makers and the people who disperse funding. A lot of the issues that we have in the community aren't because there aren't great outpatient services available. It's often because there are almost no inpatient services available. We only have, I think, about 30 beds, inpatient beds for the entire county. Alameda County only has about 65 beds. So not only is the city of Richmond competing for beds for their most ill members, but we often are competing against other counties across the state for a small number of beds to get people into various types of inpatient care. And so that's not necessarily something that I can fix or that the county can fix, but it is something in terms of advocating. We don't have those resources on the back end, and that affects everybody from law enforcement to the psychiatrist at the hospitals. It affects the decisions they have to make in the field about who now meets the criteria for being gravely disabled, because everybody understands that they're competing for the one open bed left in the county.
Yeah, and I think resources are scarce, and that's part of the problem. And the challenge is that as much as everybody's trying to do to get people into services, it's sometimes difficult because they're not there. We need more of the clinical services available for people who are ready to go. So there was one final question there that was about the percentage of people who might be experiencing mental illness or might be experiencing crisis that are actually violent. I know that you primarily deal with people who are experiencing high levels of crisis that might lead to violence. But I mean, overall, or can you comment on the percentage of people who are actually more of a harm to themselves and to others?
So I don't have an exact breakdown. We don't have a way of tracking why somebody was placed on a hold. I don't even think Psychiatric Emergency Service tracks that. Let me put it this way: the people that come to the MET team very rarely are a danger to themselves. That's not, generally speaking, the type of person that's causing a high frequency of law enforcement contacts. We may get referred a handful of them a year because they're high utilizers at PES. Most of the individuals that we work with, it boils down to a very small number of psychiatric conditions: schizophrenia, schizoaffective disorder, bipolar. Those are the big three that we deal with. We also get a lot of referrals for people with traumatic brain injuries and substance abuse disorders that are causing psychosis, even though we can't necessarily fully engage those people. Those are I'd say the big five conditions where we see severe psychosis causing violence and danger to, family members, danger to others. And across all of those conditions, the common symptomatic behaviors that we're dealing with are usually a combination of delusions, some type of hallucination, and paranoia. And the co-occurrence or comorbidity of those three is usually what's causing kind of the presentation of kind of public safety issues or danger. Just example, if you're paranoid, it means you're usually scared of something. If you're scared and you're having delusions or seeing things that aren't there, it just increases the propensity that you feel the need to lash out defensively or offensively because you genuinely feel that you're in danger. So at some level, even though they're in a psychotic state, meaning that they're having a break with reality, within their experience of reality, what they're doing is very rational. They're seeing something that's terrifying them, and they're responding in what within that context is a rational way. But just to put it, this comes up a lot in the context of homelessness right now. There are a lot of people on the street who are homeless. They have a mental health issue or they have a substance abuse issue. Very, very small number of my clients are homeless, less than a quarter. And of those who are homeless, only a small percentage who are homeless are suffering from severe psychosis. Now, they might have a mental health issue or a substance abuse issue that puts them at greater risk for losing housing, especially in a high cost housing market, right? If you have severe depression and you have a hard time getting to work in a world where houses, rent is high, that gives you a lot less resilience when it comes to being able to make rent. But I typically wouldn't be having contact with those people. And quite frankly, law enforcement, for the most part, isn't having contact. We're having contact with people who generally are experiencing some kind of psychosis. And the reality is California's mental health system is built for people who are willing and able to utilize voluntary outpatient services. We do not have a medical system that is built for people with severe psychosis. And so those are the people, whether they be vets, foster kids who now have graduated out of the foster program, no longer have the additional support. We're catching those individuals with severe psychosis because of past traumas, organic brain disorders, that the system just isn't equipped to provide services to.
Thank you so much. Now we're coming to the end of our time, but I do see one last question in the chat from Marina. How many calls do you average per month? I don't know if you have that breakdown, but I'll share that with you.
Are you talking for the Richmond Police Department or for the MET teams?
I think it's for the MET teams, Marina, or was it for RPD's 5150 calls?
The MET team.
Okay.
So we probably get about 15 to 20 new referrals a month. So we average about 150 to 200 referrals a year per team.
And that makes sense. I can tell you from January of 2021 until May of 2022, In 2020, we had 463 calls. In 2021, we had 587 calls, 2021 to 2022. So there was
Those are
some,
reports.
those are
We
the
had
actual
about-
reports.
Right.
Mhm.
We had close to 1,600 calls for service that were specifically requesting a contact due to what's called the 5150.
Yeah.
But that's a
and those
very,
are-
very rough measure that it doesn't
'Cause it
capture all the
doesn't
other
cover-
call categories.
Yeah, you're right. Because it doesn't cover every single thing, because there's some people who, you experience and you might call, or they might call and it might not show up as, something that's, would be a referral. So that
And
also
to put
accounts
it
for
in-
it as well.
To put it in perspective, last year we had about 450 involuntary holds placed by the Richmond Police Department out of a call volume of about 1,400 or 1,500 calls for service for mental health related calls. Only about 200 of the psychiatric holds came from that 1,500 calls for service. The other half of those psychiatric calls came from police officer response to domestic violence, welfare checks, suspicious persons, loiterings. So from the whole other range of contacts that officers have with the community, where they go out and realize, hey, this is not what it was reported as. This is actually somebody who's having a psychiatric crisis, and that officers resolving it, that issue, not with an arrest or report, but by diverting that person to with a kind of a medical disposition, so getting it to the hospital for a higher level of care.
Yeah. And thank you, Kristen, for saying, thank you so much for explaining this important information and the service to the community. I would agree. And, we're very lucky to have Officer Landy and somebody who has your kind of background and your kind of devotion and passion for this work to do this. It's not easy work to do. And I know that we appreciate it. And I also really appreciate that you're doing this while you're doing CIT training. I contacted him about this because it's Mental Health Awareness Month, and we did want to get him, and he was doing CIT training, and he said, is it okay if I do it in my car? I said, sure. I'm pretty sure that all of Richmond understands how hardworking, our officers are, and we appreciate you for coming and doing this. And it is Mental Health Awareness Month. So this recording, this program will be recorded so that you can send it out to neighbors and friends if they missed it, or if they want to review it. It really is important for us to spread the word about mental health, crisis intervention, and what we can do together and what we can work on together to help ensure that people get the help and the treatment that they need, and that we can avoid getting these kind of calls escalated into incidents where there's a use of force. Nobody wants to be on the other end of that. And while we might not be able to prevent everything, the more that we can do at this level, the more we can prevent those kinds of incidents from occurring. So I just want to thank you, Officer Landy. And if you have any last words, please let me know. Otherwise, we can close out.
I guess I would just leave everybody with, I get to work with all 26 of the law enforcement agencies in the county. I get to go out on lots of calls. I get to see lots of kind of the aftermath of police contacts. I would say the one optimistic takeaway I would try to leave everybody with is that your officers, for the most part, are they're exposed to a lot of crisis, and they are very experienced in de-escalation. And I think most would be delighted by what they see officers doing out in the field. It's been very illustrative for myself to be able to work with the other med officers across the county and be able to get a kind of a larger picture of what policing looks like in this county. And I think you can be fairly satisfied with the officer's ability to engage compassionately with people. De-escalation, CIT training is not new. It's been part of the law enforcement culture now for well over, I'd say, since the beginning of my career in the early 2000s. So I would leave on a note of optimism that your officers, generally speaking, are doing a very good job. You live in a county that has a very unique program like MET. There are new programs, coming online. They certainly will help on the crisis side, and that's something to be, I think, happy about. On the other flip side of that is there is still more work to be done on the longer term treatment side. Having officers who are exceptionally and exquisitely well trained in the art of de-escalation doesn't mean much if they don't have a place they can send somebody for more help. And that's, I think, where the need that I see right now is, yes, you certainly co-response with police for crisis response would be fantastic. It'd be great for A3 to expand its services. But at the end of the day, we're all running into the same problem, which is we've caught this person who was falling into crisis, but we don't have a place to take that person. And we really need those, we need places to take people, and we just don't have that.
Yeah, I agree. Thank you. And that's where you can be involved and you can advocate. As residents, you have a right to advocate for the services that you think are important. And that's one of the things that, we need advocacy at the state level on. So I hope everybody here continues to do that, as I know you will. And thank you all. Appreciate it.